During childbirth, the fetus has to pass through the maternal pelvis. At the pelvic inlet, it has an oval shape with a transverse diameter of 13 centimeters, wider than its anterior-posterior diameter of 11 centimeters. The pelvic outlet has an oval shape with a transverse diameter of 11 centimeters and an anterior-posterior diameter of approximately 11.5 centimeters. At the pelvic inlet, the orientation of the birth canal is cranial to caudal, while at the level of the pelvic outlet it is dorsal to ventral. Fetal descent through the pelvis is therefore via a 90-degree angle, shown here by the pelvic axis. An imaginary line through the center of the pelvic inlet, cavity and outlet. The fetal skull has an occipital bone, 2 parietal bones, and 2 frontal bones. The fetal skull bones are separated from each other by sutures and fontanelles. The main sutures are the frontal suture, the coronal sutures, the sagittal suture, and the lambdoid sutures. The 2 fontanelles are posterior fontanelle, which is triangle-shaped and lies at the junction between the sagittal suture and the lambdoid sutures, and the anterior fontanelle, a diamond-shaped fontanelle which lies at the junction between the coronal, sagittal, and frontal sutures. The fetal head is divided into the occiput, vertex, sinciput, and mentum, also known as the chin. These divisions are used to name the presenting part. The sutures and fontanelles are palpated in order to determine the position of the fetal head. The fetal skull has an oval shape, and depending on the position relative to the maternal pelvis, the presenting diameter and circumference differ. Now the different diameters will be explained in relation to the fetal presentation. In an occiput presentation with maximum flexion, the presenting diameter of the fetal head will be subocciputobregmatic 9.5 to 10 centimeters, with a circumference of 32 to 33 centimeters. In a vertex presentation, the presenting diameter of the fetal head will be subocciputofrontalis 10 centimeters, with a circumference of 34 centimeters. In a sinciput presentation, the presenting diameter of the fetal head will be fronto-occipitalis 12 centimeters, with a circumference of 24 to 35 centimeters. In a brow presentation, the presenting diameter of the fetal head will be mento-occipitalis 13.5 to 14 centimeters, with a circumference of 35 centimeters. In a face presentation, the presenting diameter of the fetal head will be submentobregmatic 9.5 centimeters, with a circumference of 34 centimeters. Take note furthermore of the bitemporal diameter of 8 to 8.5 centimeters and the biparietal diameter of about 9.5 centimeters, and hence the widest part of the fetal head. Once the biparietal diameter has passed the pelvic inlet, it may be assumed that the fetus can be born vaginally. With regard to the process of labour, a good understanding of the following is required. The lie of the fetus refers to the relationship between the long axis of the fetus and that of the mother. There are longitudinal lies where the presentation can either be cephalic or breech. Additionally, a transverse lie can be differentiated. The presenting part of the fetus is the part of the fetus that lies deepest in the birth canal, hence closest to the pelvic outlet. In an occiput anterior presentation, the presenting part is the occiput. In a sinciput presentation, the presenting part is the part of the sinciput that lies at or near the anterior fontanelle. In a brow presentation, the presenting part is the brow of the head. And in a face presentation, the presenting part is the face. The determining point is used to describe the position of the presenting part relative to the maternal pelvis. In a sinciput, occiput posterior, and occiput anterior presentation, the determining point is the occiput. In a brow and face presentation, the determining point is the mentum, also known as the chin. And in a breech presentation, the determining point is the sacrum. The position of the fetus refers to the orientation of the determining point relative to the maternal pelvis. The pelvis is divided into anterior, left transverse, left posterior, posterior, right posterior, right transverse, and right anterior. A notation for a left occipito-posterior presentation, for example, will be written as LOP. The attitude refers to the position of the head relative to the trunk. It ranges from full flexion, in which the chin of the fetus is pointed towards the fetal chest, to full extension, in which the occiput of the fetus points towards the dorsum. In an occiput presentation, the fetal head is in maximally flexed position. In a vertex presentation, the fetal head is flexed. In a sinciput presentation, the head is neither flexed nor extended. In a brow presentation, the head is extended. In a face presentation, the head is maximally extended. The eccentric pole is the point of the presenting part lying deepest within the pelvis, but not along the pelvic axis. In a vertex presentation, the eccentric pole is the occiput. In a sinciput presentation, the eccentric pole is absent. In a brow and face presentation, the eccentric pole is the chin. The eccentric pole follows the path of least resistance and upon descent usually rotates anteriorly to become positioned under the maternal symphysis pubis. The point of rotation is the part of the fetal body that passes under the pubic symphysis by rotation when the fetal head is being born. In an occiput and vertex presentation, with the occiput positioned anteriorly, the point of rotation is the posterior hairline. In a vertex presentation, with the occiput posteriorly, the point of rotation is the anterior hairline. In a sinciput presentation, the point of rotation is the glabella. And lastly, in a face presentation, the point of rotation is the larynx. Syncletism and asyncletism Describe the position of the sagittal sutures relative to the pelvic axis. With posterior asynclitism, the sagittal suture is positioned in front of the pelvic axis, in the anterior plane of the pelvis. With synclitism, the sagittal suture is in line with the pelvic axis in the anterior plane. With anterior asynclitism, the sagittal suture is positioned behind the pelvic axis in the posterior plane of the pelvis. In labour, the following 7 sequences are the cardinal movements of labour. Engagement. Engagement is determined by the amount of head that is above or below the pelvic brim. Engagement is complete when the widest diameter of the head or breech has passed through the pelvic inlet. Descent. Descent is downwards movement of the head in the direction of the pelvic outlet. This occurs simultaneously with engagement. For a more detailed elaboration on this, refer to the course Planes of Hodge and Fetal Stations. Flexion. Flexion takes place due to the resistance that the head encounters from the cervix, the walls of the pelvis, and eventually the pelvic floor, and causes the fetal head to bend so that the chin is touching the fetal chest and a smaller presenting diameter is created to pass through the maternal pelvis. Internal rotation. Internal rotation is necessary for the fetal head to be able to pass the pelvic outlet, and takes place due to both maternal and fetal components. The 2 fetal components that facilitate internal rotation are the flexibility of the head relative to the trunk and the eccentric pole. The maternal components are the strength of the contractions, the resistance of the maternal tissue, and the shape of the birth canal, which curves in a 90-degree angle towards the ventral side of the mother. Extension. With extension, flexion decreases due to the forward bending curve in the birth canal. The head extends and is borne by rotation around the symphysis. External rotation. During external rotation, internal rotation of the shoulders takes place to be able to pass the pelvic outlet. This can be seen outside by an external rotation of the head around the long axis of its dorsum. And lastly, expulsion. During expulsion, the remainder of the body is born.